we'll go straight across to the next presenter, and that's Dr. Beena Thomas, who is a social scientist and former Deputy Director at the National Institute for Research in TB at the Indian Council of Medical Research. And Dr. Thomas will be talking to us about understanding care-seeking behavior for TB control. So over to you, Beena.
Thank you so much, Kiran. I must thank the MSF, and I'm so happy to be here on their Asia Scientific Day. Okay, so the topic that I have been asked to speak on today is understanding care-seeking behavior for TB control. While we talk about care-seeking, my focus is going to be on the tribal population, because that's what I was asked to speak on, given that we've just come out with a recent publication from India. So just to give a prelude about what is really health-seeking behavior. So health-seeking behavior, like it explains, is what people do, in terms of what they perceive as ill health. What's the action or the inaction that is taken? So why do we really need to understand care-seeking behavior in the context of TB control? Because it's all that, I would say that is the most important phenomenon that is neglected. If one has to think in terms of not just TB control, we are talking about TB elimination, we are talking about the NTB strategy. If we do not understand health-seeking behavior, we are nowhere near that. So just to give you some of put that in context, it's to understand the epidemiology of TB in the community, to understand transmission dynamics. And here again, we find that the TB program in most countries is based on passive case finding, which means people with symptoms have to access care. So the onus is on people. And what happens when they don't? We had a session this morning on multi-drug resistance, XDR. So we need to nip it in the bud if we don't have to end up with things like MDR and XDR. And again, if you need an NTB strategy, like I said, health-seeking behavior is the most important, piece in that big puzzle. So what are the drivers of care-seeking? There are, if you look at the global picture, I was doing a lot of homework before I took this presentation today, and I find that, it's almost similar in most countries globally, as well as most importantly in Asia, because we are focusing on that, where you find there are so many different constructs of the illness. If you look at TB or you look at any illness, it depends on what people think it's all about. So that is something that as a behavioral scientist, which I was able to, realize in my work with TB, that so often we as program people, or, we dictate, we decide what people need to know. We do not, ever try to take stock of what they perceive as, as illness, as TB. So I was talking to Raj, and when we were preparing for this, and we were saying in HIV, it was already decided by the program. You tell them how HIV was spread. And, you talk about the cause, you talk about different things, but you never understand the misconceptions that they had. So it was things like, oh no, we knew about HIV, but that's something that we truckers, it's part of our occupation, because we do, leave home for months on end, and sex is part of us. So we believe that, after that, we come back to our trucks, and the heat of the engine kills germs. So similarly in TB, sometimes you think, what misconceptions can they have? But there are so many different misconceptions. Thinking it's a disease like I said, in Southeast Asia, it's a disease only for males, or it's because of some evil spirit, or it's because of water. It can be because of food. There are so many different perceptions that they have, which sticks to them. So it depends on how we kind of communicate to people, and especially here we're talking about the tribal people. And one of the things that we found, through all our studies, was this big lacunae that we have in terms of awareness. Like I said, I would like to repeat, what do we mean by awareness? What do we mean by knowledge? So I come from NIRT, which is the National Institute for Research in Tuberculosis, where I just superannuated. And we have done a lot of work in with regard to health-seeking behavior. So that goes from the general community, that is both rural and urban. We have done it on migrants. Now we just completed a study on the tribal population, which I'm going to focus on today. So just to give you a kind of a peep into what was already done way back in 1997, it's almost, if you look at, it's almost 3 decades. We found what are the health-seeking behavior patterns. There again, you find that it was just 30% who, sought care. What are the reasons for not seeking care? It seemed to be the same between rural and urban. Where lack of severity of symptoms, lack of knowledge, like different connotations where gender came in, where males, their health-seeking behavior was totally different because they were preoccupied with work, or there was alcohol and so many deterrents that prevented care seeking. For women, of course, it's caregivers and home remedies and, taking their whole, their illness for granted. So that's something that all women do. Now, when we come to the tribal population, why did we think of doing that? Because you find that 8% of our population is tribal, and there was very little work done on the healthcare seeking behavior among the tribal population. So I've given you the link there. So what did we try to do? We were trying to find out what are the drivers of care seeking. And this is so important in terms of early diagnosis and treatment. Now, this is part of a larger study that we did, which was to estimate the burden of TB among the tribal population, because there again, we had very few studies and mainly in central India. And when we did a meta-analysis, we found it was 703 per 100,000, which was much more than the general population. So this was a need-based study, and health-seeking behavior was also part of it. So I'm just going to present about that. So this was a community-based study in 17 states. Like I said, it was a very large study across 6 zones. We covered 88 villages, and what we called the tribal district was where the tribal population was over 70%. So the participants that we screened were around 74,000 and odd, above 15 years of age. And what did we find? We found there were 3.6%, that is 2,675 individuals with presumptive TB. So this was similar to what we did in the general population. There it was around 2 to 5. But among the brick-in workers, which I didn't allude to, we found that the percentage was around 9%. And there again, we found their health-seeking behavior was so different because they were migrants, and they were practically locked into their brick-ins the whole day. So when do they seek care? Where do they seek care? When it's such a temporary arrangement. So what I would like to give you in these little pictures is just to give you that one thing I'm really happy is that I've gone to all these places and every interior village in the study. And that is something I think that as investigators, that's something that I would like to leave behind. Very often we sit in our ivory towers and we try to collect data, which is there in the field. Investigators are collecting it. But if we really have to have a feel of, these hard to reach populations, there's nothing like being there in person. So if you look at it, these are the housing conditions. There are still traditional healers, and there's this general belief that, most tribal, people go to these traditional healers. Actually, that has kind of come down. There are very few of them. So if you look at the difficult terrain there, it was the way that our vehicle had to go through that is just, one vehicle can go at a time. And if, God forbid, if another vehicle comes, the other side, that's it. There's no way. Who reverses? And for our bad luck, our vehicle got stuck. So we were stuck there for quite a few hours. But that said, just shows what do those, we are just going there on a visit to kind of oversee our project. But imagine what people really go through. Or you have truckloads of people, or it is carrying them, on that, what they call it, it's like a stretcher where they carry it manually, or they're sitting on bikes. And this is the kind of terrain that you have. It was very nice to see, the different kind of people. Early morning, they would have their hadia, or they would have their mahua, all their local drinks, or even the women smoking. That's part of their culture, but you have to weave it through their culture. You cannot bring in your kind of views on them. So how you approach these people has to be done so carefully. So if you look at the difficult terrain that, we had to, this was one of the places where we went, where we had to cross through water and go through. It was difficult, but it gave me that feeling that I was able to understand what they were going through. So just to give you an idea of the results of our study, like I said, it was 2,675 symptomatics. That was, and how many of them sought care? The same thing that we heard, 30 years ago almost. Again, 30% only sought care, which means around 25%, around 75% did not seek care. And here we found there was a delay again of around 25 to 30 days. That was the delay in health seeking. So this is what I said. And what are the factors that influence care seeking? Again, we find knowledge. Knowledge is what comes in, in all the studies that we've done earlier. And when I was reviewing the literature across the globe, this seems to be the most important thing. But the question is, what is knowledge? And then you find that people with comorbidities were the ones who sought. Why? Because in any case, they were going to a health center. So then, if they had respiratory symptoms, they would be referred. So these are the kind of, drivers of care seeking. So what are the reasons why they did not seek care? So here you find lack of money was one of the most, because, it takes a lot to even, to get a vehicle to go, or to even get, someone to come and take you on a bike, or people to carry you. So lack of money. And one of the major things that we found was this not perceiving their symptoms were severe enough. And that was what we saw not only among the tribals, but also in the general community, among the brick workers. And then, of course, there were problems with access in terms of distance. And one of the things that I would like to say, even there, it was a dissatisfaction with the health facility. But what was interesting is that we found there was really not much of a difference in where they access care. So it was both private and public. Unlike what we saw in the community way back in 1997, it was people who would go to the private first. And then in 2007, we found that it was actually people who would go to the government, which means that the facility was kind of aware of it. And, they had kind of revamped their services. So here you find there's not much of a difference, because there's really no choice. And if you look at private, what we mean by private is a lot of them wet quacks. We were there, practically witnessing when we were visiting, one of the tribes. But there was this person with a white and white, he poses himself as a doctor. He's come with this whole lot, and we're talking about AMR. He had a strip of antibiotics in his pocket, and he had a syringe. God knows what they do. But for them, private is, these people who go to their doorstep and give care. So these are the factors that influence care seeking. And here what I would like to highlight is the symptom, because one of the things that program or policy always look at, what are the symptoms that, drive people to seek care. And if you look at the symptoms here, it's mainly blood and sputum, or it's fever, weight loss, shortness of breath. And I would like to also bring in the gender differences here. Among males, it was mainly blood and sputum, weight loss, and shortness of breath. For females, again, it was blood and sputum. So this seems to be the most important symptom for them, which kind of prompted them to seek care. But symptoms like cough, really did not, chest pain or loss of appetite, which is the symptoms that the program goes on harping, and did not seem to really prompt care seeking. So if they did not have blood and sputum, or they did not have shortness of breath or weight loss, it didn't seem to be severe enough for them to seek care. And I think this is something that we need to keep in mind. So just to give you a summary of the results, like I said, 75% did not seek care. 1/3 of them delayed it for more than a month. The different reasons for not seeking care. And here again, I'd like to reiterate that knowledge was the most significant factor. But the question is, what knowledge? Influence of traditional healers was minimal. Cough, which is the most often reported symptom, is not a symptom that really prompts care. And males were more likely to, there were differences in gender in terms of symptoms that prompted care seeking. So to conclude, I would just say that delayed health seeking is a problem even among the tribal population, but the need to focus on tribal friendly interventions in terms of being aware of their sociocultural factors and the kind of IEC or the knowledge that we are going to impart to them should be something that is reachable to them, which takes note of what they perceive as TB, or what they perceive as important to seek care and what they perceive as not important to seek care, which so often we do not take into account when we prepare our awareness campaigns or our information, education, communication material. And the fact is that sometimes we also notice that whatever was available was so wordy and very little that could really reach out to them in ways that they would understand. Because like I said, knowledge seems to be a very important part. You can't really say alcohol intervention, and that is a little far-fetched, considering that that's part of their culture. So sometimes I've heard you need to do alcohol intervention. What intervention? So I think the key is also the need to think in terms of tribal-friendly interventions and gender-based, because what males feel and females feel can be a whole lot different, and one needs to take note of that. So the take-home messages is that whether it is in India or globally, care-seeking behavior continues to be a challenge, and we are talking about it for decades. And we are talking about NTB strategy, but we really haven't, concentrated on the need for healthcare seeking behavior interventions. We need to think of gender differences in this. We also need to think of health system strengthening, which is very important. If when they seek care, what awaits them there is most important. And the kind of things that they came out, there's nobody there. The centers are all closed. Like the photograph that I show you, when we went there in the morning, sub-centers are closed, or it's just for the sake of having a name that it would be there. They are not functional. The program is all that it should be within 2 kilometers or tribal friendly. The tribal plan is different, but actually what's happening in the field out there is so totally different. And while cough we consider as a cardinal symptom, it doesn't look like that is the kind of symptom that prompts healthcare seeking behavior for TB among the tribals. So the need to concentrate on healthcare seeking behavior. A man too busy to take care of his health is like a mechanic who's too busy to take care of his tools. But it's not just the question of this, it's also the question of what they consider important. Thank you very much.
Thank you very much, Dr. Beena. Fascinating presentation. And we have a few questions coming in already. Can I just encourage anyone else to put your questions in the Q&A boxes, and we'll try and come to them if we get time. So the first question was, obviously, understanding health-seeking behavior is critical for person-centered care. And these are valuable tools for ensuring we deliver services that meet people's needs on their terms. But I want to ask you, is this sufficient on its own? And do you think that health-seeking behavior surveys are enough? Or maybe to put that differently, are there any risks from relying on health-seeking behaviors to understand the needs of that population?
No, I wouldn't say it is. It is a very crucial component. I mean, it's not just alone, but with health-seeking behavior, what do you offer them? I think everything has to follow an intervention as well. So it's not just understanding health-seeking behavior. What do we do with that understanding? Very often, it just stops with that. So that is where I think we go wrong. And then we are quickly thinking in terms of, those who attend the health centers, referring them for care or trying to initiate treatment. But then what's the follow-up on that? I think that's
yeah. Okay, great. A second question around stigma. Was this an important factor when considering health-seeking behavior among tribal population groups? And if so, could you say a word about that?
Very interesting question, Kiran. And I was really appalled because there is hardly any stigma among the tribal population. And it's amazing how, they kind of accept each other. That's why I said, sometimes, in this whole experience of working with the tribal population, you have so much to learn from them. Stigma it just doesn't seem to matter. If there is someone with TB, all of them know about it. And they are not discriminated. That sometimes you think, whether the lack of knowledge is a good thing or a bad thing. In terms of stigma, I would say it's a good thing. But in terms of, health-seeking behavior, it's not so good. But no, stigma wasn't a problem from the experience that we had.
Okay, that's interesting. Thank you. Yes. So a different question now. How significant is the role of training community health workers in providing better access to care? Was this also considered a challenge in care delivery?
Absolutely. Because I would say, again, the terminology community health worker, who are they? You know, this whole concept of ASHA, 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 that seems to be, you know, something that's most often repeated. And when I was in, you know, like I said, I've been able to visit all these places. You find there are so many other people who you can call community health workers, tribal youth. You know, many of them are sad, they don't have a future, but they were so vibrant. They are the ones who would come with us. Where, you know, these people don't feature in that, you know, that list of health workers. There are women, there are men there who are, you know, who are accepted in the community. But the whole focus is on ASHAs, and ASHAs are overloaded with so many other different things. Today they are interested in TB. Tomorrow malaria is offering them a better incentive, or COVID is offering them a better. They are there. So I think it's time that we think of who are the other community health workers. I wouldn't say volunteers, because we need to pay them and they need jobs as well. And they are the ones who are most willing. So I'd say the training and capacity building has to reach them in a language that they understand. You know, there was hardly any tribal friendly materials.
Yeah, okay, great, very clear. Another question, little bit linked to one of the earlier questions. Do you think that fear and denial is a factor affecting health-seeking behavior for TB in this population?
Again, I would say fear doesn't seem to be part of their vocabulary. I mean, they just live one day at a time. One of the things that fascinated me was, you know, we used to be, to reach the tribal village, you have to be there before they get into the forest or they leave out. So, you know, somewhere to get up at 4:30 in the morning and be there at 6 o'clock. And it was amazing to see even the women quite tight in the morning, you know. So it's like they just live for the day, and they're not even worried about, you know, what's in store for them. So fear, I would say, is, you know, not, I wouldn't kind of associate them with fear. But denial is, again, how do we kind of define denial? Because for them, cough is something that all of them seem to have, because smoking is, again, part of their culture. So women and men are coughing. So they wouldn't, you know, associate that with TB. So in that way, it's denial, saying this can't be TB, you know, because it's part of all of us have it and it just comes and goes. So I wouldn't say denial for fear of TB. No, not for that. But it's just that they lack of, you know, awareness.